So thank you for having me here. So my name is Dr. Rahul Banerjee from the Hutchinson Cancer Center in Seattle, Washington, in the United States. And it's an excellent question. What is the impact of dexamethasone dose strength on outcomes in newly diagnosed multiple myeloma? So, as all of you are well aware, dexamethasone, or Dex, as I'll call it, has been a mainstay of our treatments for decades for myeloma. There was a large study 10 to 15 years ago. Dr. Rajkumar was a lead author on the publication that showed that, we used to give Dex even higher, 40 milligrams in pulses for 4 days on, 4 days off, et cetera. And they compared that with Dex about 40 milligrams weekly and found that Dex 40 milligrams weekly was the sweet spot for patients, actually less mortality with that quote unquote lower dose of Dex. Most studies since then have continued to use Dex approximately 40 milligrams weekly in different dosing schedules of 20 milligrams on sequential days versus 40 milligrams weekly, et cetera. And we don't really know if that's the optimal dose. We know that Dex 40 is better than Dex higher than 40, but in the real world, and particularly in patients on clinical trials, is Dex being reduced further than that? And for patients where that happens, do they do worse? The reason for that is that Dex has a ton of side effects. So many of you who are listening to this are well aware of the side effects of high-dose steroids once a week: insomnia, anxiety, edema. Our group has published work with the Health Tree Foundation showing that lifetime Dex exposure, which can often go into grams, not milligrams, is a key driver of visually significant cataracts that prevent people from driving and being able to see properly. Studies have shown that Dex prevents, even if people think they're sleeping well, they're not sleeping well when they're on Dex. It can lead to polypharmacy, many oral medications. There have been studies that show that if you drop the Dex after 9 months in older, frailer patients, they also do better. And so we thought to look at, larger studies of triplet regimens, of quadruplet regimens, and in particular, two large SWOG studies, cooperative group studies. One was VRD versus RD, SWOG 777, and one was ELO VRD versus VRD, S1211, with the idea of one, identifying what the prevalence is of Dex dose reductions, even for patients on trials. Patients on clinical trials often, they're volunteering their time. We don't know what the right answer is. So investigators are often more reluctant to change the dosing around of medications. But even in those trials, what was happening with Dex? And two, for those patients where the Dex was reduced, did they do any worse? Was there any harm done if we dropped the Dex for side effects or patient preference or so forth? And so we looked at those two SWOG studies, S0777 and S1211. These are both US patients with multiple myeloma, newly diagnosed, patients from immediate transplant was not planned. They enrolled patients between 2008 and 2016, respectively. So none of these patients, for example, got a CD38 monoclonal antibody. And we pooled data across arms and looked at what we found. So the first conclusion, the first question I asked, so 69% of patients overall, of 541 patients altogether, 69% had lower Dex doses at the end of induction versus the beginning of induction. That was the same, more than half of patients across every arm of every study. So it is very common, even in clinical trials, for the Dex to be dose reduced during induction. We weren't able to capture why the Dex was dose reduced. I suspect that adverse events like I alluded to, insomnia, difficulty sleeping, weight gain, irritability, anxiety, were probably a big driver of them, high blood sugars. We tried to compare the full dose Dex group versus the reduced dose Dex group. And, obviously it's not a randomized comparison. We actually found that the reduced Dex group maybe had slightly higher disease burden as measured by bone marrow plasma cell percentages. And most importantly, and as you'll see when I presented this data as an oral abstract at the ASH meeting, 2023 American Society of Hematology meeting earlier this week, we found no difference in patients who had full dose Dex versus dose reductions during induction in terms of PFS, which is length of remissions, or overall survival, which is how long they live. The curves were absolutely superimposable. As a kind of guardrail, we did look at the patients who had their Dex stopped entirely, even on clinical trials, which is pretty unusual, especially in this era. These trials were run, almost a decade ago. It was only 40 patients out of 500 plus, so maybe 7% of our cohorts. They were much older. About half of them were age 70 or older. For those patients, there was a reduction in PFS and a trend in length of remission and a trend towards decreased overall survival. But again, that was 40 patients, much older than the rest of the cohort. And so there are probably some confounders there. And so kind of taking things home here, in terms of our two aims, what we sought to figure out here, one was how common is Dex dose reductions? Very common. Probably suggesting that our starting dose of dexamethasone, 40 milligrams weekly in most modern trials, is probably too high if even on clinical trials, over half of patients on every arm and almost 70% of patients overall are getting their Dex dose reduced. Overall, dex dose reductions had no impact on PFS and OS. There was the caveat that we did try to look to see if patients who had extreme dose reductions, who ended up being much older, frailer patients, if they had worse PFS, and they did. But again, that was a clinical trial, and in the era of newer CD30 monoclonal antibodies like daratumumab or isatuximab, unclear what the significance of that particular point is in the modern era. And so I would argue that if you were to try to lower dexamethasone dosing in trials going forward, I think that we would likely benefit patients for all the studies I mentioned earlier in terms of fewer cataracts, in terms of less difficulty with sleeping, probably better bone health and muscle health and so forth, unlikely to worsen PFS and OS, and probably more reflective of how dex is actually dosed. Because on clinical trials, if in any other scenario, a medication was being dose reduced this often, even on a clinical trial protocol, you'd say, huh, starting dose is too high. The max tolerated dose has been reached. We got to go down. For dexamethasone, we haven't been doing that, and maybe we should. There's some limitations, obviously. We didn't know in all cases why dex was being dose reduced. We didn't have that kind of granularity captured in the data. We didn't have cytogenetic data in terms of high-risk fish findings. These were technically transplant ineligible patients between 2008 and 2016, so they may have some limitations to patients being enrolled today. And of course, I do readily acknowledge that I do use dexamethasone for my patients very routinely during cycle 1, the first cycle of newly diagnosed myeloma treatment, because it has a lot of good benefits there in terms of pain control, rapid disease debulking. Some of our modern monoclonal antibodies can have a risk of infusion reactions, injection reactions, and dexamethasone can help with that. But after the first cycle or 2 cycles, unclear how much is adding in the modern era, if no impact on PFS or OS here. So our clarion call based on these data, and we're working on different prospective studies, is to really push for the field to say, look, let's kind of right-size how we're dosing dex in our studies. Perhaps dex 20 milligrams and not 40 milligrams should be used in all of our patients, not just age over 75, but even all patients. Or after 1 to 2 cycles, dex should be reduced or stopped entirely. So with that in mind, I will close and thank the team at the SWOG group and the CRAB group and everyone who participated on the trials, and most importantly, the patients who participated on these trials. And thank you all for your time for listening.